So could you start today by telling us your names, roles, and institution?
Sure. So I'm Dr. Marsha Michie. I'm an associate professor in the Department of Bioethics at Case Western Reserve University School of Medicine.
And I'm Professor Megan Allyse. I'm also an associate professor of bioethics at the Case Western Reserve School of Medicine.
Great. And can you provide a brief overview of your SCGE project and explain your roles in the project briefly?
Sure. So we have a sort of a sub role on the UL1 grant that's held by Dr. Ahrens Nicholas and Dr. Musunuru called Personalized Prime Editing as a Platform for Hepatic Inborn Errors of Metabolism. And our role on the project is doing community engagement with the urea cycle disorders community about the move towards potential gene editing treatments for urea cycle disorders. And we have established a partnership with the National Urea Cycle Disorders Foundation. Actually, Dr. Ahrens Nicholas has had a relationship with them for quite a while, but we've established a partnership with them. We have worked with them to develop an interview design, a study design, an interview guide, and all the materials that we will send out to their community. And we're going to be doing individual interviews with people who themselves have urea cycle disorders, adults who have them, and also parents of children who have urea cycle disorders to talk about the potential for future gene editing, particularly clinical trials, and what their priorities for those will be.
How can researchers ethically balance getting therapies approved quickly and properly testing safety and efficacy of these therapies?
That's really the central tension for developing these kinds of therapies is that, especially when you are working on a condition that has very serious impacts for very vulnerable young babies, obviously everybody wants to move as fast as we possibly can. And that was what happened with what I'm sure many of your viewers are used to or familiar with is baby KJ, where he had a very serious condition that about 50% fatality rate. And they were able to work very, very, very fast and get a custom therapy available for him. However, that was sort of a one-time first in humans thing, and it's not going to be replicated, right? So the future, that's not scalable. So in the future, it's going to be a matter of researchers working very closely with the Food and Drug Administration to make sure that we move as fast as we can therapeutically, but also responsibly. And that means having more regulations in place that are custom to this kind of technology that really address the strength of this technology, but also make sure that we're taking into account the ways that this technology can be unsafe or in some ways ineffective. Luckily, the Food and Drug Administration has indicated that they're very willing to work with the scientific community in this regard. So earlier this year, it was announced that they had put together a new regulatory pathway that allows scientific researchers to very rapidly get feedback from the FDA to get new therapies into clinical trials faster, while not compromising on the safety and efficacy trials that we all know are necessary to make sure that we're doing this responsibly.
Well, I think that what we emphasize in our ethical scholarship in this area is that we're not really thinking about making hard and fast rules about whether or not we do this kind of research, but it's really in how we do it. And we want to integrate justice considerations into the details of how we develop this technology, how we develop trials, how do we address this, the ethical obligation that we know we have to promote access to therapies that are proven to work once they are proven to work. And so these are really important aspects of the research, and we're so happy that the study that we're part of at Children's Hospital of Philadelphia has emphasized the importance of engaging with the community to make sure that they proceed in ways that retain the trust of that community and prioritize what's important to the patients and their parents.
Informed consent is crucial for patient involvement in research. How can researchers adapt patient educational materials for people from different cultural, linguistic, or educational backgrounds?
we've actually done a lot of work in this space, and one thing that you learn is it's really difficult to make things scientific language readable and understandable to people who haven't heard it before. And it's especially difficult to do it yourself when you're really steeped in that scientific technology and terminology and jargon. Luckily, there's lots of experts out there to help you with that kind of thing. We do this kind of work in our work as ethicists to think about informed consent documents, pamphlets for patient education that people would be reading as part of that informed consent process. But we also rely on other people, people who are experts in plain language. If we're thinking about material in other languages, we would always go to a native speaker, even if we thought we knew how to translate something, we'd always take it to a native speaker, preferably multiple native speakers, to make sure that they are able to think about maybe even dialects. That's really important. We had a study a few years ago, and the word that we had gotten from our translator for genetic variant was a word that in some dialects we didn't know, but one of the native speakers working with us said, that's really kind of a derogatory word in this dialect, and I don't want to use that word. Let's think of another word to use for genetic variant in this context. And we would never ever have known that. And it's something that we have to rely on expertise, just like we rely on genomic expertise for the research. We rely on language expertise, educational expertise, ethics expertise, and so on. But I'd say the very, very most important thing is to engage with these populations, the populations that you're going to do research with. You want to get their perspective. In our case, we worked with them to design things. We asked them about the pictures we were going to use. We asked them about the colors we were going to use. We asked them about all these things, and we were able to get their perspective. And then the next step that we're doing in this project is to pilot all of the things, the recruitment documents, the interview guide, and everything with people from that community, because they're going to think of things that we never thought of. And so we have long ago let go of the hubris that we know what's best for other people. We really, really need to work with those populations to make sure that they let us know what's important to them and about all the things that we're blind to, because we will be.
Years ago, we were doing a study on hereditary breast and ovarian cancer, specifically in Black populations. And we partnered with a community advisory board of individuals from that community who had experience with breast and ovarian cancer. And we sent them just one of our recruitment flyers where one of our students had put little flowers all along the edge of the flyer because she thought it would be pretty. And the flowers were pink and green. And our board came back immediately and said, you absolutely cannot use pink and green flowers. We had never occurred to us to worry about what color the flowers were. And they said, well, pink and green are the official colors of one of the largest Black sororities. And if you use those colors, then they will think your study is affiliated with that sorority. And people from other sororities might not think it's for them. So you have to change the color of the flowers. Not in a million years would we have known that the color of the flowers on this recruitment flyer would be a message, would send a message to that community. You cannot know that unless you spend the time to go to the community and say, tell me what this is telling you and what message it's sending you. And then we can decide together if that's the right message that we actually want to be sending.
Great. We're going to switch topics a little bit now. So what are some of the ethical concerns that are unique or specific to in utero gene editing therapies?
Okay, so in utero gene therapy is a really, really interesting, promising. If you're talking about in utero therapies, you're still talking about somatic gene editing. So you're talking about just changing the fetus, the genome of the fetus, and not their future children. Sometimes people misunderstand that, but just like editing a person who's already here, you're not changing anybody but the person in front of you. And so for the fetus, it's just that fetus. It's also not really clear that some of the treatments that we're doing need to be done in utero, but some do. We have some precedent about the risks and benefits and considerations for this from the therapies that we already have available for in utero, like parental fetal surgeries, for example, uterine surgeries during pregnancy. So we know that we need to think about this inextricably linked pair of the pregnant person and the fetus. There's risks for both. Pregnancy is a particularly interesting state, dynamic state. It changes really radically over the course of those 9 months. And so risks to the developing fetus are not the same in month 1 as they are in month 4, as they are in month 8. And so you really, really have to think about what stage the fetus is at in that place. So that's a particular biological, physiological thing that you have to think about when it comes to delivering a therapy like that. And then in general, you have to think about the risks to the pregnant person because what we know is that even in just an everyday pregnancy, cells from the fetus will often embed themselves in the pregnant person's body in random other organs, and that can persist throughout her life. And so, if those cells are gene edited, what does that mean for her? In general, you want to think about things like future reproductive capacity, various things like that. But these are considerations because you have this patient in front of you that is a potential future person and an existing person right there together. And you need to consider the risks and the benefits to both of them together. And it's really, really challenging, but it is promising too in many ways.
There are some conditions, when Dr. Michie says promising, there are some conditions in which it makes sense that we may want to intervene during pregnancies. And those are generally conditions where the development of the fetus is hampered by a genetic condition. So if you look at Duchenne's muscular dystrophy, for instance, it significantly impedes the development of the muscles in the fetus. And that means by the time the baby is born, a certain amount of damage has already been done. And the amount of therapy that we can give that baby is lessened because we're starting from a place that's with less functionality than before. So in conditions like that, what we would call degenerative conditions, it can make sense to intervene during pregnancy and stop that damage. And that means that they will have a higher functionality when the baby is born. So those are some places where you would say, well, maybe ethically it does make more sense to explore a prenatal application than a postnatal one. But again, that's not all conditions. Most conditions, the damage starts once the baby is born, and so it makes sense to wait and do the therapy either neonatally or in infancy.
And this question is kind of timely with the news. How would you help the public understand the difference between treating a serious disease before birth, in utero editing, and manipulating traits for non-medical reasons?
I think the most important thing that people understand is that somatic gene editing, which again is what we're talking about here, is done in a single individual. Whether that's a fetus or a baby or an adult, it's one individual. And it's done for things that are very, very small, right? So the kind of conditions we're talking about are differences in one gene. And there can be different differences in genes that cause the same kinds of conditions, right? So you could have one condition, but there are multiple uh, genetic changes that cause that one condition. But they're all single gene, and that's why we're able to go in and edit them so precisely. So that's what we mean when we say gene therapy for a genetic condition. If you are talking about changing the entire genome, and you want to say, for instance, as you mentioned, the work in Colombia that was trying to remove a single gene from an embryo, then it's really much more difficult to do that. We don't know if it'll work in an embryo, right? Because we don't know what happens after that embryo starts to divide and meiosis occurs. Is it actually going to go into every cell in the fetus's body, or is it going to be mosaic? The bigger issue is that when people talk about non-medical traits, they're talking about things like intelligence or height or athletic ability. These are not things that are due to one gene. They're due to thousands, if not millions of genes. And more importantly, they're due to the interaction between those genes and the environment, whether that's the uterine environment, whether that's the neonatal environment, whether that's the pediatric environment. Every day, your genes are changing. And so there's no way, really, biologically, that we would be able to go into an embryo and make any kind of change that would meaningfully change these sort of large macro traits that people talk about. If you're talking about very, very specific things like eye color, maybe, but then why would you? right? And I think that every time this comes up, somebody mentions the movie Gattaca, which I think we're all familiar with, in which they have genetic engineering. Um, and I think that a lot of people miss the central message of Gattaca, which is not that genetically engineering humans leads to dystopia. It's that genetically engineering humans doesn't work. It doesn't do what you say it does. That's why one astronaut gets to go into space, even though he hasn't been genetically engineered. So I do think we spend maybe more time than is necessary worrying about this idea of genetically engineering non-medical traits. There's really nothing you could do genomically that wouldn't be much easier and more efficiently done socially.
So in the next 10 years, what is something that you predict or hope will happen in the gene therapy field?
Well, I'll start because I think that we also work a lot in the space of genetic screening and testing, especially in the perinatal period, pre-birth, post-birth, preconception, and that field is advancing really, really rapidly right now. There's a lot of big changes happening in how much information we can give people at what time period. So we can certainly test embryos for a lot more things than we used to be able to. We can test the whole genome of a developing fetus now, and soon we will probably be able to do that non-invasively, just with a blood sample from the mother. There's already been proof of concept of that, and now we're looking at everyone gets newborn screening now, and we're looking at enhancing that newborn screening. There's a study from the NIH right now, a big study with many, many states studying what it would look like to give people uh, hundreds and hundreds of genetic results along with that, with just that one newborn screening sample. So all of those things are going to make a big difference to our ability to think about genetic therapies. So, for example, if we are enhancing newborn screening with more and more genomic results, that means that we might find conditions much earlier that then could be treated much earlier. In other cases, it might be that we would get results prenatally and we'd be able to start customizing a genetic treatment for somebody that's available at, minutes or hours or days after they're born, instead of waiting to find out, oh, this mysterious condition is happening. What is this? We wait a while, we get to diagnosis, and then we get to treatment. And I really think that that's going to be one of the biggest things that's going to change this area is, of course, the therapies are advancing and they're getting more precise and they're getting more feasible. But in fact, the information about us and about our future children and living children is going to really, really enhance our ability to create and deliver those treatments it much, much quicker, much earlier, and much more efficiently.
Well, that was Marsha's very optimistic take. I will say that I think there is a tremendous amount of work that needs to be done to ensure that these treatments are made available sort of in a just, fair way. That we are already seeing, if you look at recent trials of the sickle cell therapy, for instance, significant differences as who can access that therapy, what impact it has on them. And some of that is financial, some of that is geographic, some of that is biological. Some of these treatments work better for certain genetic anomalies than others. And so I hope that in the next 10 years, we continue as a field to work very, very hard to address those justice issues just as hard as we're working on the scientific issues to make those therapies more effective.